So I don't have any financial disclosure. And at the outset, I would thank Scientific Committee AIOS for giving us this opportunity to present our instruction course in front of our audience. So my topic is Introduction to Lasers, History and Mechanisms. I'll just give a brief introduction about the history, how the lasers have evolved over a period of time since the 1930s and 1940s, and how lasers work, specifically PRP laser in retinal diseases. So we've all heard about laser. Laser is an acronym, as we all know. It stands for light amplification by stimulated emission of radiation. But then what is maser? So maser is microwave amplification by emission of radiation. So the idea of laser was derived from maser, and the person who invented maser also got a Nobel Physics Prize for the development of masers. And then later on, we started developing further technologies like laser, which we use in retinal in ophthalmology diseases nowadays. So these three gentlemen contributed a lot to the development of lasers. The one on the right with his tongue out, as we all know, is Albert Einstein. He predicted that light waves can be amplified, and these light waves can be amplified to. He predicted this way back in 1917. The gentleman on the left is Dr. Meyer Schwickerath. He's the one who invented the first laser. Along with the gentleman on the right side bottom corner, he's Mr. Hans Littmann. He was a physicist at Carl Zeiss. So these three are important people in the development and history of lasers. And Meyer Schwickerath is a German ophthalmologist who invented the first laser which was used clinically. So where did he get his idea from? So he was inspired by a solar eclipse. In around 1945, a lot of patients started visiting Dr. Schwickerath after viewing a solar eclipse. And when he examined their fundus, he noticed that they all had some macular lesions and some lesions on the retina, which we now know as photic retinopathy. So he realized that sunlight can be harnessed using lenses and to photocoagulate retinas in case of certain diseases. So he started taking patients of melanoma to the roof of his clinic and tried to harness sun and photocoagulate the retinas. But he realized that this had a lot of problems. The sunlight was not predictable. It was very inconsistent. Also, because of the constant motion of the earth and the sun, he could not give consistent and deliverable results constantly. So he started working with Littmann at Carl Zeiss, and he developed the first xenon arc photocoagulator in 1956, which became commercially available in 1958. This was the first laser which was developed for retinal diseases. So this is a picture of that retinal. It was a huge machine, actually very bulky machine, and this was what he used for delivering lasers. But these xenon lamps, they had their limitations. The spot size of these lamps were very large. It was very difficult to focus, and this was polychromatic light. So it faced a lot of difficulty, and it was difficult for a clinical practice to maintain such a machine because of the large size and the intense burns of xenon. And these burns used to cause some vitreoretinal traction because of the intensity of the burns. Also, the xenon lamps had poor collimation. The direction of the laser was not as good as the lenses which came out in the future. So along the same time, Maiman developed a ruby crystal laser in 1960, and argon blue laser was developed in 1965. Now, when these lasers were developed, there was the famous diabetic retinopathy study, which showed that lasers decrease severe vision loss in diabetic retinopathy. So in this study, xenon versus argon laser was also compared, and they realized that both these lasers decrease severe vision loss in diabetic retinopathy, but the VR traction effects which were seen with xenon, these were not seen in argon laser, and then hence argon lasers became much widely used compared to xenon. But these were all gas-based lasers. These were bulky and water-cooled, and these lasers had fragile gas tubes, so they were difficult to maintain at a clinical practice. So around the same time, L. Aspran started conducting studies on ND-YAG and krypton laser. And nowadays, the commonly used lasers are green laser 530 nanometer, which we use routinely, which is frequency doubled ND-YAG laser, the yellow laser, and the infrared diode laser. These three lasers are the ones which we use commonly nowadays. So now if we talk about further advancements, there is a separate topic which Dr. Piyush Kohli will discuss, but I'll just mention them. They are pattern laser, which is Pascal or Iridex machines. Then there is Micropulse laser, and there is a NAVILAS laser, which is the only slit lamp based laser. So now I move on to mechanism of laser. So laser, there has to be some properties of light or properties of laser which make it very useful to treat retinal diseases. So these three properties make it very useful. One is that monochromaticity, which means that there is a single wavelength. All these particles of laser are in phase, so the energy delivered can be very consistent, and the laser light are collimated, which means they are parallel and they maintain the same direction. So the power can be titrated accordingly. These three properties make laser very, very useful for use in precise delivery of laser inside the eye. And as we know, that eye is one of the main organs in the body where laser is used extensively. So now we go to the mechanism, how laser PRP works in the retina. So retina has dual circulation with a watershed zone. Majority of oxygen supplied to the choriocapillaris by the choriocapillaris is to the outer retina. This blood does not reach, this oxygen does not reach the inner retina usually. So inner retina, which is supplied by the central retinal artery, and in this diagrammatic representation we can see the diffusion of blood by the choriocapillaris in the outer layers. So what happens in ischemic disease like diabetic retinopathy or vein occlusions or even ROP is that there is a lot of non-perfusion of the retina, which causes hypoxia and CNP areas. And so these CNP areas release some angiogenic factors like VEGF. So when these VEGFs are released, there is a formation of neovascular tissue. This neovascular tissue has a tendency to bleed and cause vitreous hemorrhage and other tractional complications which we see in ischemic diseases. These usually form at the junction of perfused and non-perfused retina. So when we do a laser, this laser gets absorbed by pigments, which is melanin in the RP and hemoglobin in the blood. It causes thermal coagulation. Usually there is heat generation at the RP level, and at any duration of laser above 200 milliseconds, this spreads to above 100 milliseconds, this spreads about to the photoreceptors and destroys them, causing a thermal coagulation and glial cell formation. These photoreceptors get destroyed at higher temperatures, and there is also constriction of vessels. So this, when we put a thermal burn, we can always see the burn expanding, which is called thermal blooming. So this thermal blooming effect is because of the increased duration which we give in a single spot laser above 100 millisecond duration, which is prevented in the newer lasers. So now once we have destroyed the outer retina, the oxygen from the choriocapillaris can reach the inner retina. It improves the oxygen tension and improves hypoxia. And so the demand supply mismatch which had happened because of the ischemic disease process gets resolved. So the newer lasers, which I'll just mention briefly, are the pattern laser. Now these are shorter pulse lasers. The duration of these lasers is only 20 to 30 milliseconds. So they give less energy, less chorioretinal scarring. The burn does not bloom, and they also have certain beneficial effects compared to regular lasers. I'll just mention the next two. One is Micropulse. These are the only lasers which you can give at the macula. So rest of the lasers you usually avoid the macular area, but this laser you can paint over the macula, because these are short pulses of energy with only a duty cycle of 5, 10 to 15%, the details of which Dr. Piyush Kohli will explain later. And these avoid thermal damage and lateral spread. They spare the photoreceptors. The thing is, they don't have any visible endpoint, and these lasers can be repeated multiple times. And just to complete, the NAVILAS is the latest laser, which is the only fundus camera based laser. The physician has to import images from his fundus fluorescein angiogram and infrared images. He can mark the optic nerve head and fovea, and this machine has eye tracking technology, so it does not hit the fovea if the patient moves his eye. And this is my presentation for the day. Thank you. I would like Amit sir to carry on the